I love the title, Big Problems in the Small Bowel. And I can tell you ampullary adenomas can really be a big problem. So ampullary lesions comprise only about 5% of GI neoplasms, but we're identifying these more frequently on routine endoscopy. Most of these, as you know, are asymptomatic. And most of these lesions are adenomas on our biopsy. Occasionally, we will encounter a subepithelial lesion at the ampulla. Most of these are neuroendocrine tumors, but sometimes we may have a stromal cell tumor, a GIST lesion, or even a lipoma. So should we treat or watch an asymptomatic, incidentally found ampullary adenoma? So there's absolutely no consensus on this. But we have some guidelines based on our management of polyps, for example, in the colon. So we all know about the adenoma to cancer sequence for colon polyps. And we know that for ampullary adenomas, actually, the risk of developing cancer is greater than that of colon polyps. There's about a 30 to 50% risk of malignant transformation. We also know that in patients with FAP, there's a 100 to 200-fold increased risk of progression to cancer. We know that biopsies may miss a focus of occult neoplasm, and that can occur in 30%. In fact, if you look at the pathology series, up to 50% of ampullary adenomas had foci of cancer. And then there's simply the issue of patient preference. So the patients are anxious about a tumor in their small intestine, and they want it out. So those are the arguments to treat. But there's also a strong argument to watch because the risks of removal may outweigh the benefit, even in a patient with FAP. We don't know a lot about the natural history, but what is very compelling is this paper by Matsumoto and colleagues published in 2000. They looked at 18 ampullary adenomas in patients with FAP, and they followed these patients for 10 years. None of these patients developed cancer. In 88%, there was no change in the dysplasia grade, and there was no change in tumor markers. So an argument could be made also for watching. Now, the historic treatment has been, of course, surgery, and the patient could have a Whipple operation. That'll cure an ampullary adenoma, but it comes, of course, at a high cost of mortality up to 10% and morbidity 50 to 60%. And I think we'll all agree that this really is excessive treatment to do a Whipple on a patient with basically a benign lesion with a risk of potentially becoming malignant. So what about local resection? That makes, of course, better sense. But we know from the literature that there's a very high recurrence rate after surgical ampulectomy in 17 to 38% of patients. These lesions may be inadequately resected, and 50% would explain the high recurrence rate. And these patients may go on to develop malignancy, in which case they'll need a second operation. So I was very privileged to be in Hamburg working with Nib Sahendra in the 90s, and in 1993 we reported the first large series of endoscopic snare excision of benign adenomas of the ampulla fodder or the papilla fodder. 25 patients, all with benign adenomas less than 4 centimeters. We did have bleeding in a few patients and pancreatitis in a few patients. In 2 patients we found intraductal tumor extension into the bile duct, and those were sent to surgery. On pathology, high-grade dysplasia in 1, but no cancer found. We did have a high recurrence rate of 26%, and 5 of the 6 patients with recurrence could be retreated endoscopically. I think what we have learned is that for endoscopic resection, careful patient selection is very key. We have to make sure that the lesion has a benign endoscopic appearance. There's no ulceration, there's no depression, there's no friability. It should have benign histology, and you should obtain multiple biopsies. And there should be no or very limited intraductal growth, extension up into the bile duct. But most importantly, we have to be sure that these patients are compliant and that they will return for follow-up post-resection surveillance and possible retreatment. And that's because, and this is a theme I'm going to harp on a few times, the recurrence rate is very high. I want to point out that the term papillectomy and ampulectomy really should not be synonymous. We should reserve what we do as endoscopists to the term papillectomy. Ampulectomy should be reserved for the surgical resection. So the surgeon actually will resect part of the distal bile duct and the distal pancreatic duct. We do not do that. We're only resecting the papilla. So we should technically refer to this as papillectomy. So how do we evaluate for intraductal growth? Well, traditionally it's been ERCP, but as everyone who does ERCP knows, when you're faced with a large ampullary adenoma, you may not be able to cannulate the bile duct to assess for intraductal extension. So that's why it's nice to do an endoscopic ultrasound before embarking on an ampulectomy, and you can similarly see this growth extending up into the bile duct very nicely on EUS. But in addition, with EUS, we can do local T-staging. And just be sure that we can follow the muscularis propria. You can see the dark band on the outside here. That's the muscle layer. And we can be sure that we are not facing an invasive malignancy, as shown here. Is there a size limit? Is there any lesion that's too big? Well, when we reported our early series in the 90s, we limited these to lesions less than 4 centimeters, and others sort of followed suit and said, okay, let's limit this to 4 centimeters. But then there was this study by Howell's group, and they decided to be bolder and resect lesions also larger than 5 centimeters, and then they compared the resection of lesions that were less than 3 centimeters and greater than 3 centimeters, and in all of the categories that they evaluated in terms of outcomes, there was no difference. So probably size doesn't matter, and I think that makes sense. As this has evolved over time, we've become bolder and we have tackled these larger lesions, just as we do in the colon with large polyps. So now let's turn to technique. Well, the fact is there simply is no consensus. There are many variations. There are many unknowns. We don't have randomized trials to really guide us as to how we should be resecting this, which technique to use. So the questions are, should we inject submucosally before we resect, as we do in the colon with colon polyps? Should we use cutting or blended current? Should we place a pancreatic stent? Should we do that before we do the ampulectomy or afterwards? Should we do a biliary sphincterotomy? And should we be stenting the duct, bile duct, and or pancreatic duct? And what about adjuvant ablation, for example, with APC? Should we be doing that after the resection? So I can't provide you with the answers. I can only share with you how I do it. So this is my personal technique. I always start with a preliminary EUS. I want to get an overview of the anatomy. I want to assess for intraductal growth, just as I showed you earlier. If the lesion is less than 3 centimeters, I will attempt an en bloc resection. But if it's larger than 3 centimeters, I will do this piecemeal. Obviously, if we can get en bloc, that's preferred with clean margins. I will use selective submucosal injection for laterally spreading and caudal components. I'll show you that in a moment. I always do a cholangiogram and a biliary sphincterotomy, and then a balloon sweep. It's important to use a balloon to occlude and literally evert, to pull out the distal bile duct to assess for any adenoma that may be extending intraductally. And sometimes I'll even put the cholangioscope up to look myself inside of the bile duct. And currently, I'm still placing a pancreatic stent prophylactically, but that can be debated. So the technique that we described in the early 90s is called the craniocaudal approach. The idea is to impact the tip of your snare above the ampulla at the infundibulum, and then to sort of pivot it down using that tip of the snare as a fulcrum. So here you can see the impaction of the snare tip above the adenoma at the infundibulum, and now we're going to swing the snare down as we're opening it, and then we're going to engulf or encompass the entire lesion. In this case, it's less than 3 centimeters, so our goal is an en bloc resection. And we also look to make sure that we have free margins around the lesion. You could also mark the perimeter with some diathermy if you wanted to be sure that you have captured the entire lesion for an en bloc resection. So this is a nice example of how one might do an en bloc resection. Obviously, you need to capture your specimen very quickly, maybe give some glucagon beforehand to make sure it doesn't swim downstream with peristalsis, and then we can cannulate the bile duct and then proceed with the next steps, which would be sphincterotomy and placing a pancreatic stent. And I'll show you that in this video, which shows the use of selective submucosal injection. You can see this lesion is extending now more caudally below. We're using the saline lift to bring that lesion more towards the operator so that we have a better chance of capturing the entire lesion. And once again, it's a fairly sizable lesion, but relative to the size of the snare, we can get this out en bloc. So our goal is always en bloc if possible. So with the help of that selective submucosal injection, we're able to remove this lesion. So here you can see a biliary sphincterotomy. I think that's very important to do that, to open up the bile duct. And there is a small risk of stenosis afterwards if you don't do a biliary sphincterotomy. You can see the cholangiogram here, but as we all know, you can miss a lesion on the cholangiogram, so I like to just throw in my, my endoscope. This is direct per oral cholangioscopy. That's how we prefer to do it if the bile duct is large enough. Once you have a nice opening, it should be easy to pass your scope up there. Now, what about intraductal growth? I believe that if it's limited, I'd say a centimeter should be the maximum, and you can evaluate for that both on ERCP and EUS. I think it's okay. I think if it's more than a centimeter, then I think realistically you cannot guarantee a cure anymore, and these patients really should be sent preferentially to surgery. So once again, the same technique is shown here. This is the appearance after the papillectomy, now our sphincterotomy. Now you noted that after the papillectomy, you did not see these fronds of villus adenoma because they were tucked up inside of the bile duct. And it's fairly bulky, but it's really more polypoid, and it really is originating from the papilla itself rather than from the bile duct. Again, our cholangioscopy is ideal to confirm that we don't have any adenoma up in the bile duct. So if possible, it's always best to directly visualize the bile duct. Now, what about complications? There have been over 700 published cases. Bleeding and pancreatitis are the most common complications, occurring in about 10% of patients for each category. Amazingly, perforation is very rare. So in this compilation of the world's literature, it was less than 1%, and there's a near zero mortality. So this is really good news for ampulectomy in terms of overall outcomes. Now, the question of whether to place a PD stent always comes up in our meetings, and if you look at the literature, there really isn't a correlation between the placement of a pancreatic stent and the incidence of pancreatitis. We did not place pancreatic stents, and we had a risk of pancreatitis that was 12%. Another group placed stents in 85% and had a higher rate of pancreatitis than we did. The only data that we have that has guided us now is this very small study from the Mayo Clinic, and it was actually terminated early. So it was a prospective randomized controlled trial of prophylactic pancreatic stent placement after ampulectomy or papillectomy. And you can see that actually in this randomization after 10 patients, there was a significant difference in the incidence of pancreatitis. The investigators decided to terminate the study early. And I think that's just not fair. We definitely need a legitimate study to prove whether we should be stenting the pancreatic duct or not. But what we do know is that recurrence after papillectomy is, in my opinion, still unacceptably high. If you look at the literature, you see rates, ours in the early 90s was 26%. But have we gotten that much better over time? And you see 33% and 33% in several studies. So you definitely can't have 1 out of 3 patients having a recurrence. At a minimum, we have to make sure that our patients are coming back for surveillance at 3 to 6 months. And obviously, the intensity of that surveillance is going to depend on the size of the lesion and whether there's high-grade dysplasia and whether there's intraductal growth. Now, in the last remaining minute, if I could have it, underwater EMR is sort of a little hobby of mine that's evolved over time. I've used it in the colon to resect colorectal polyps. I've used it in the duodenum to resect duodenal adenomas. And so I've also experimented with underwater papillectomy. So I'm definitely into the scuba diving within the GI tract. And the advantage of this method is that you can float the adenoma to facilitate the snare capture. You can actually use a caudal cranial technique rather than having to revert to the craniocaudal. And there are some theoretical advantages. The technical simplicity, you can capture actually more tissue because the mucosa and the submucosa, the ampullary tumor itself is more involuted and folded on itself, and you can achieve a more superficial plane of resection in the submucosa, and that may result in a lower bleeding and perforation risk. And so this is just a very quick video showing the method of underwater papillectomy. This is something we'll be publishing on very shortly. We've now done about 30 papillectomies with very interesting results. So here you can see we filled the lumen with water, and you can see how we can use this caudal cranial approach because literally this ampuloma, it floats into the open snare. So we don't have to dig our snare as aggressively against the mucosa to capture it. It captures us, so it floats into the snare. After the resection, it's easier to capture the lesion because it floats within the water, and this is the appearance after the resection. And the plane of resection is not down at the muscularis propria, it's actually within the submucosa. It's in layer SM2, at most SM3, and that's why there's a lower incidence of bleeding. Here's the sphincterotomy, and then here the pancreatic duct cannulation. So the rest of the procedure, of course, is no different than what I showed you before, and placement of the pancreatic stent. So in conclusion, endoscopic papillectomy has become first-line treatment in appropriately selected patients, and we need to very carefully select those patients for endoscopic treatment. EUS is valuable in staging and to evaluate for intraductal growth. There are many variations in technique. We need those randomized controlled trials. We need standardization going forward. The high recurrence rate continues to worry me. At a minimum, we need intense, frequent surveillance. Thank you.
Thank you very much for a very interesting and excellent talk. I think we have time for one question now. Other questions about this talk can be done at the end of the session.
Thank you. After ampullary, suppose that pathology reveals carcinoma, which was not evident before ampullary, and the margins are clear, and the patient is relatively young. What will be your advice?
Yeah, so I think that the rules are no different for an ampullary adenoma than they are for a colon polyp. So I think if you have achieved an en bloc resection and your pathologist can confirm that you have both vertical and horizontal clean margins, and this is carcinoma in situ, or it is not invasive beyond the lamina propria, I think that that can be considered curative. I would definitely be concerned if it's invading into the submucosa. As you know, in the colon, if it invades into SM1, you're still pretty good because the risk of lymph node metastases is less than 2%. That does not apply to the duodenum. So I think if you have any invasion beyond the lamina propria, well, then you better be calling the surgeon.
Thank you very much.
Thanks, Ken.